Ladies and gentlemen, please welcome the President and CEO of the Cystic Fibrosis Foundation, Dr. Preston Campbell.
Hey everyone, welcome. It's great seeing you here in Denver for this year's North American CF Conference. It's great being together. You all are an amazing group, a great group of people, and it's always a highlight of the year to get together. I also would like to welcome our many friends who are joining us online. Thank you all for being part of this very important event. I hope that those of you online find it both helpful and also very, very encouraging as well. I know that a lot of folks on the CF Foundation team, both in Bethesda, Maryland, and in chapters across the country are watching, so a shout out to you all and thank you for being part of the team. Now I want to thank you all for all that you do for the mission of the Cystic Fibrosis Foundation. Since you've been gone, since you've been away from this meeting last year, you've been hard at work. Many of you have created new ideas, and it's every year we see people sharing these ideas, and often collaborations arise that will end up really accelerating our progress and making a difference for people with CF. So we really want to thank you. I have a disclosure slide. I'm happy to report that I have, maybe it's already been shown, but I have nothing to disclose, and there's a CF Foundation common disclosure as well. All right, so here's the deal. At the risk of sounding like I'm sucking up really big time, I just have to say that the CF Foundation board is the best nonprofit board in the world. Can you give a round of applause to that? They're fantastic, and they do so much to help us meet our mission. Of course, a great board requires a great leader. And today it's my privilege to introduce the chair of the Board of Trustees at the CF Foundation. It's also a good friend, Cam McLeod. Cam, would you come join me? So many of you know Cam because she's been here many, many years, 17 or so years, or 19 years, just about every year at the CF Foundation North American meeting. And you know what a difference she's made in how much she cares for you all. And I'll just tell you that most of the exciting advances that we're going to talk about this week would not have been possible without her leadership. So Cam, thank you.
Thank you, Preston. Thank you, Preston. I'm very humbled. It is an honor to welcome all of you to the 32nd North American Cystic Fibrosis Conference. This year, we're more than 5,000 strong from over 40 countries. Just look around you. At the exemplary care teams, the dedicated scientists, and the passionate volunteers. What a special and talented group. I thank each of you for your tireless commitment to working together to help people with CF live long, healthy, and fulfilling lives. Your important and innovative work is transforming people's lives. I also want to share a welcome with those of you who have joined us online today, especially those people that are joining us with CF. You are the reason that we are here today. And you inspire us for all that we do, and you make our team stronger. I'm delighted also to welcome some of our fellow board members here today, along with the team from the CF Denver chapter and volunteers from around the country. Thank you for your incredible commitment to our shared mission. It is truly an exciting time for the CF community, and I'm looking forward to learning more from all of you during the next few days. Our progress has been amazing across the board, especially with the CFTR modulators, but also in drug discovery, clinical research, and care. Modulators are helping thousands, and we now have in our sights new therapies could bring effective treatments to as many as 90% of individuals with CF by next year's NACFC. And we could not have done it without each and every one of you. You've made this astounding progress possible, and you continue to help build the momentum that we will need to achieve even greater progress in the future. Now, the road to effective treatments for many individuals with rare and nonsense mutations will be longer. But I can promise you, our resolve has never been stronger. And more than any other community in the world, we are fueled by something very unique: hope. I'd like to share something with you today that captures just what this hope means.
My little one, as I hold you in my arms, I think so many things. How perfect you are. Your fingers, your toes, those little cheeks. How I love hearing you breathe. I have so many dreams for you. I hope that you will have the courage to face life's challenges and never let cystic fibrosis define you. We're behind you every step of the way. I hope that you build lasting friendships because they are what life is all about. And I hope that you achieve your goals, whatever goals they may be. We'll be cheering you on. I hope that you find someone to love, and that someone is lucky enough to find you, a person who is stronger than you know, who isn't afraid, who stands tall, who reaches for the stars, and then reaches again. Let nothing hold you back. My little one, my dreams for you are so big. And while the selfish part of me would like to hold you forever, I dream that one day you will grow up and live out dreams of your own. For all those living with cystic fibrosis, we dream of the day when CF stands for Cure Found.
Wasn't that beautiful? That's the power of hope. I've been part of this extraordinary community for 34 years since my son Will was diagnosed at age 2. He had 2 nonsense mutations. What bound me to the CF family was the relentless commitment to progress. I lost Will 2 years ago. But that inspiring commitment and our unstoppable progress keep me firmly within this determined and united global family. By staying together, I know that we will reach our common goal and commitment to find a cure for all people with CF. We are deeply fortunate to have each and every one of you, the best and the brightest, by our side as we move closer and faster toward our common goal. Through your hard work and spirit of collaboration, you're bringing hope to people with CF and their families around the world. Thank you so much for being here, and I wish you a wonderful conference. I get to say something about Preston. I'm not going to. Now it's my honor and pleasure to welcome someone back to the podium who everyone in this room has deep respect and admiration for, both professionally and personally. Hi, friend Preston Campbell.
Cam, thank you. You know, I love the CF story. It's the most amazing story in medicine today, and it's a story of remarkable progress enabled by an extraordinary community, you all, many here today who share a dream to cure cystic fibrosis, and we've come a long ways. You know, for example, when the CF Foundation was started in 1955, there was nothing. And I think it's important for people who are new to CF to understand this. There were no CF doctors, no CF medicines, no CF clinics, no CF science, and worst of all, there was no hope. Parents were told, love your child, but be prepared to lose them. Because of you, because of all of you, caregivers, scientists, industry partners, volunteers, and most important, people with CF and their families, people with CF are living longer, healthier lives. We have more hope now than ever before. So that's great, but if we look forward, and the North American meeting gives us an opportunity to look forward, what does the future look like? Well, I think the best is yet to come. Hopefully next year will be a pivotal one for our community. Assuming success in the ongoing phase 3 programs, we anticipate that 90% of the population in the United States with CF will be able to benefit from Vertex's highly effective next generation CFTR modulators, also known as the triple combination or just simply the triple. Those with 2 F508del mutations who are currently on Orkambi or Symdeko will have significantly better CFTR restoration with the triple. And those not on the modulator now, who have just 1 F508del mutation, will have access to highly effective treatments for the very first time. Now, this was unimaginable in 1955, but also it was unimaginable just 10 years ago. Now, as great as this sounds, we also know that we're not done yet, as Cam alluded to earlier. 90% is certainly not good enough. We're committed to improving these transformative therapies to getting these transformative therapies to everyone, 100% of people with CF. We will not leave anyone behind. So the question then becomes, how then do we get to 100%? How do we do that? Well, for the 10% who do not have an effective modulator treatment in sight for their CF, we're focusing on 3 approaches. The first approach is that we will identify people with rare mutations that will respond to the available modulators. These rare mutations have not been included in the ongoing CFTR modulator trials, and so we don't really know if they're going to work or not. Did you know that there's over 1,000 CF mutations that affect 5 or fewer people worldwide? In fact, some of these mutations will respond to the available modulators. In fact, we believe that 3% of people with CF in the United States who are not on modulators now have rare mutations that will respond to these available modulators. And we know this because we've been really hard at work evaluating their response, these mutations' response to the available modulators in the laboratory, and using that data to make sure that these individuals will gain access to these therapies once they're approved very quickly. Now, the second approach is to advance therapies or treatments for people with nonsense mutations. Success with therapies for people with nonsense mutations will add another 3%. So we would be at 96% with that of people in the United States. How robust, you might ask, is this effort? Well, we're currently screening over 3 million compounds, chemical compounds for nonsense mutations, as an effective therapy to read through this premature stop. That's a lot of compounds. For example, the Vertex first CFTR modulator screen that gave us ivacaftor, Orkambi, and Symdeko screened 400,000. The point of my telling you this is that we're being very, very aggressive to find treatments for these people who have nothing at this time. Also, the Foundation's lab outside of Boston commits half of its research efforts to find new treatments for research for nonsense mutations. And we're seeing early success or hits across these programs. Besides these small molecule screens, we're also basically funding very novel approach outside of small molecules to further diversify our approach and increase our chances of success in bringing these very needed therapies to people with nonsense mutations. Now, what about the last 4% of people? Well, the last 4% will need another approach because their genetic mutation will not result in any rescuable CF protein or any CF protein at all. And that's why we are aggressively pursuing new approaches such as delivering a normal copy of messenger RNA or DNA to the cell to make a normal copy of the CF protein CFTR. Now, if you've been around for a while, you may be thinking, you know, these approaches don't have a great track record. Well, the science of genetic transfer has come a long ways in the last 20 years. It's a very different field today. And if, having said that, all of this still sounds like a pipe dream to you, let me tell you that already the first messenger RNA approach for people with CF is in clinical trials at this time. And there is also a number of gene therapy approaches that are being moved forward towards the clinic at this time as well. So getting to 100%, making sure everyone has a therapy for their CF is going to take some time, but I'm actually very confident, as Cam said, that we're going to get there. Now, switching gears, the rapid advance of modulators and other novel approaches gives us great hope for the future for sure. But at the same time, we have listened to our community, and we know that people with established lung disease need better antibiotics, better anti-inflammatory therapies, better mucociliary clearance agents right now and in the future. And in fact, as you'll soon hear, we project that even 20 years from now, approximately half of people with CF will still require these therapies that treat the complications of CF lung disease. So the question again now is, well, are we making any progress in these therapies? And the answer is yes, and you'll be learning more about that in today's plenary and tomorrow's plenary. Today, Dr. Bill Skatch is going to set the stage in a really, I think, great way for Dr. Lisa Saiman, who's going to talk about our efforts to bring new antimicrobials and a robust antimicrobial program to people with cystic fibrosis. I think you're going to be very pleasantly surprised at all that's going on. And you'll see that there is hope, even hope for those with multi-drug resistant organisms. And tomorrow, in the second plenary, you'll hear from Felix Ratchkin, who will update you on improving inflammation and mucociliary clearance in the last 5 years. In the last 5 years, we've made a lot of progress as we've increased our focus on these specific areas. But as you all know, particularly the clinicians and the caregivers in this room, that improving the lives of people with CF goes well beyond new therapies. We're taking a multi-pronged approach to helping individuals manage the rigorous daily treatment regimen. At the core of this work are the partnerships between people with CF, their families, and clinicians. In the plenary on Saturday, Dr. Maureen Batalden will take a fresh look at the relationships that make up this partnership and explore how integrating the voice of the person with CF, the most important voice in this partnership, can help us find new ways to improve CF care. So you're going to want to see that. Of course, care and treatments must be easily accessible, and thanks to you all playing a significant role, we continue to fight for people to make sure that they have adequate, affordable insurance and access to high-quality, specialized CF care. Now, once all of this is in place, 100% of people have a treatment that addresses the basic defect for them. The other available therapies that they need are in place, and we can ensure people that they have access to the highest quality of care and the treatments that they need. We will still not be done. When you walk into the CF Foundation offices today, you'll see the words, "until it's done," emblazoned across the wall. So what do we mean by this? Our dream is that one day, people can say, "I used to have CF." This, of course, will be possible because of advances in gene editing, gene therapy, or other approaches. And at that time, and only at that time, will we be done. Let me just tell you, the future is bright. We do have a long ways to go. We're not done. But the hope of fulfilling our dream will keep us going. By staying together and working together as one team, we will certainly cross the finish line. So let me end by thanking you all for all that you do to make this dream come true. Thank you very, very much. Now it's my pleasure to introduce, I think, my first hire at the CF Foundation, Dr. Chris Penland, who is our Vice President of Biopharma Programs. Chris has played an important role in bringing hope to people in our community through his leadership in advancing both the research and industry partnership collaboration. So Chris, thank you.
Good afternoon, everybody, and welcome to those joining online. I have the pleasure of introducing two groups who are very important to the success of this year's meeting. First, I'd like to recognize the Program Planning Committee, and I think I'm advancing my own slides here. There we go. This group began their efforts shortly after the conclusion of last year's meeting and have worked diligently over the past 12 months to craft the scientific content for this year's meeting that I think that you will find very well-rounded and engaging, and that I hope you will enjoy. Now, the efforts of the Program Planning Committee have been led by the program co-chairs, Drs. Ronald Rubenstein and Heather Hawthorne. I would like to invite both of them to the stage now to receive a small token of our appreciation. So we'll make sure that these get shipped to you. So it's also my pleasure to recognize important participants in this year's meeting, and those are the exhibitors and supporters. I would encourage you to visit their booths in Exhibit Hall D and engage with their representatives to learn more about what they're bringing to the meeting this year. Finally, it's my pleasure to introduce Dr. William Skatch, the Foundation's Senior Vice President of Research Affairs. After more than 20 years of leading his own laboratory, Bill joined the Foundation almost 5 years ago to lead our research, drug discovery, and early drug development efforts. Bill will provide a brief update on CFTR modulator advancement and then establish a vision for ongoing therapeutic needs that Lisa Saiman's presentation today and Felix Rotchin's presentation tomorrow will complement. Bill, welcome to the stage.
So thank you, Chris, and good afternoon to all of you. I'm absolutely delighted to be here today to begin the first plenary session. You know, Preston commented that we're really kind of at a pivotal point in CF history, where drugs like ivacaftor, lumacaftor, tezacaftor are really transforming CF in more and more patients and at younger and younger ages. My role in the next 10 minutes or so is to give you a very brief update on what's happening in these areas It kind of set the stage for both opportunities and very exciting new things that are going to happen, as well as challenges that we will still face in the long run. So the title of this seminar, or this plenary, is Improving Outcomes in the Age of CF Infections. And I'm going to give nothing about infection, really, but really talk about modulators and where we are. If you think about CF and its long history, it's really gone through several different stages. Preston mentioned the early days when there was no hope, there was no treatment. That gave way to an era where there was improved care and scientific discovery, where in just 34 years, the median age of survival rose from less than 5 years to 30 years of age. And with the historic cloning of the CFTR gene, it set another pathway in motion to understand how genetic defects cause disease, and really led to the discovery of drugs which could overcome the effects of those defects. And that really started the modulator age in 2012 with the approval of ivacaftor, followed by lumacaftor-ivacaftor, and then tezacaftor-ivacaftor just this year. This now extends modulator therapy to 60% of the individuals with CF. But just last August, the approval of these drugs was extended to people, children, 1 to 2 years old. So think about that. It's now possible to turn on CFTR long before significant lung damage has occurred. And this really transforms where we're going. But things are looking better in the future. Last February, Vertex Pharmaceuticals reported phase 2 studies showing that 3 drugs given together are even more effective than the 2 drug combinations we currently have. This data was provided by Vertex Pharmaceuticals, and it shows that individuals with one F508del mutation treated with tezacaftor-ivacaftor plus a new drug, VX659, actually had an increase in their FEV1 of up to 13% and a drop in their sweat chloride of 51 milliequivalents. A second trial using a different drug, VX445, showed similar results. And these 2 trials then led to 2 new trials, phase 3 studies, which were just started this year. VX659 and tezacaftor and VX445 plus tezacaftor are now being given to individuals with 1 or 2 delta F508 mutations, and they have enrolled incredibly quickly. The 659 trial is already completed enrollment. The 445 trial is following closely behind. The results of these trials are expected out by the end of this year and early next year. And if the trials are positive, Vertex will submit to the FDA approval for one of these combinations by mid next year, 2019. That's really pretty remarkable. At the same time, it's important to recognize that other companies are also developing triple combinations. Proteostasis Therapeutics is developing 3 drugs, an amplifier, a potentiator, and a corrector. And this data provided by PTI shows that when 2 of these drugs, VX809 and 801, are combined, they generate more chloride current in the laboratory than the Vertex double. And the Vertex triple also generates more chloride current in the laboratory than a Vertex triple. I'm sorry, I think I might have said that wrong. The proteostasis triple generates more chloride current in the laboratory than the Vertex triple. So these 2 combinations now, both the double and the triple, are in clinical trials. And while the trials are still ongoing, an early evaluation of the double was just reported yesterday with positive results. So we're very excited to see how those trials finish up. Galapagos is another company developing modulator combination therapy. They have, like Vertex, a potentiator and 2 correctors, which are currently in clinical trials in Europe. I don't have any data here, but the Falcon trial is now looking at those combinations in people with either 1 or 2 delta F mutations. So the most amazing thing about these trials is that a single F508 mutation generates as much activity as ivacaftor does in G518. And you don't even need, it doesn't even matter what the second mutation is. One delta F508 mutation is enough to cause these kinds of effects in patients with CF. So what can people expect in the long term? This is a graph that many of you have seen before that shows how modulators can affect long-term lung function decline. And the red line shows what shows that without modulator therapy, lung function declines from early age over time, such that it reaches about 30% by age 45 or so. As shown by the blue line, ivacaftor and G551D cuts this rate by about a half. So that over the long term, if someone has started on this therapy at, say, age 6, there's an enormous benefit to preserving lung function. And this is why we think that in the future, people with CF could live to 60, 70, and even 80 years old if they go on these modulators early in life. And even though ivacaftor, lumacaftor, is less effective in the acute effects on FEV1, on lung function, this is data that the dashed line shows data by Michael Constant that there's still a long-term benefit on lung function in starting individuals early in life on the lumacaftor-ivacaftor combination. So now we have the opportunity to start even earlier and using modulators that are even more effective. So what does that mean? Well, it may be possible in the future to even preserve lung function even better over the long term. There's another aspect of this graph which is very, very important, and that is the red line is unacceptable. What we really need to do is move the red line further up so that people that cannot benefit from modulator therapy will still be able to preserve their lung function. And this is really what the next two plenaries, today's plenary and tomorrow's plenary, is all about. How can we take people that will not benefit from modulators and preserve their lung function over the long term? We think this is eminently possible because if you think about the history, we've moved that red line from about 5 years of age to 45 years of age already. And with further therapies and further developments, we think we can go even, we think we can do even better. So to get a little different picture of the road ahead, last summer we estimated how modulator therapy might affect the overall population. And this shows that today, about half of people with CF are adults, about a third of them have healthy lungs, shown in green, a little under half have some degree of lung dysfunction, shown in pink, and a small fraction, shown in dark blue, have advanced lung disease. If we assume that the triple combination modulators are highly effective and become available in the near future, then several things emerge. First, people will be living longer and longer than ever before with CF, and the population size will grow. Second, if you look at the green bars, more and more people will have completely healthy lungs. And third, over the course of about 20 years, more than 2/3 of people with CF will be adults. But even with modulators, and 20 years from now, we expect that there will be a significant percentage of the population that will still need additional therapy, that will still have some degree of lung dysfunction. And this means that as we go forward, there are still some very significant challenges. First, as Preston mentioned, not everyone will benefit from modulators. Even with 93% of the population getting adequate treatment on modulators, there will still be 7% that are not covered. And these individuals require life-saving therapies to preserve their lung function today, while we develop drugs and therapies like mRNA, like nonsense therapies, like gene therapy and gene editing. Some people will have already existing lung disease and they will need continued therapy. Some infections may be extraordinarily difficult to eradicate even when people go on modulators. And lung function still may decline at a slow rate for some of these individuals. So for many reasons, treating and preventing the complications of CF remains a major priority, whether they occur in the lung, the liver, the pancreas, or other tissues. In this respect, when we polled the CF community, the #1 top concern for people with CF, as well as clinicians and caregivers, was the damage caused by chronic lung infections, particularly those by resistant antibiotics. So we took this to heart, and to address this challenge, I am absolutely delighted today to announce that the CF Foundation has committed $100 million over the next 5 years in a bold new initiative called the Infection Research Initiative. The mission The mission of this initiative is to improve detection, diagnosis, and treatment of outcomes for people with CF. This is a major investment that will support a broad and comprehensive program that will fund basic research into understanding infections and their causes, their outcomes, as well as drug development and new therapeutic approaches for improving treatment. We could not be more excited about this initiative and are confident that the results of this effort will have a major impact for people with CF. Now, I'm neither a microbiologist nor an expert in infectious disease. So it would be rather foolish for me to speak much further on this topic. But I am delighted that we have with us a true expert in this area, Dr. Lisa Saiman, to present today's plenary lecture. Dr. Saiman is a long-standing leader in our community, a professor of pediatrics at Columbia University, where for more than 30 years she has dedicated her career to understanding, preventing, and treating infections to help us in the CF community to address this challenge for people with CF. There is no one more fitting to present this lecture, so please join me in welcoming Lisa Saiman to the stage.
There are a lot of you. It's my absolute pleasure to be here today, and I think I'm in a really remarkable position. It's a little, I'm confessing that I was at the first North American CF meeting, and I'm in a very unique position to be able to tell you where we've been, where we are, and where we're going as we work together to improve outcomes of infection in the age of CFTR modulators. So, Bill, okay. So here's my disclosure, and really what I want to say is today that I have the privilege and responsibility of presenting the research and insights of countless individuals from the CF community. And so my objectives today are to identify ongoing challenges in the treatment of infections in people with CF and discuss the potential impact of CFTR modulators on infections. I'm going to update you on the results of ongoing work to improve our understanding of CF microorganisms, including detection, diagnosis, and optimal treatment, and end with a discussion of current strategies that will result in the new anti-infective therapies of tomorrow. So this schematic is really a testimony to so many of you that collect the data on CF microbiology and then transmit it to the foundation, and then it turns into our registry. The registry is able to share with us the CF microbial burden and the treatment challenges that we engage with today. This figure shows us the overall prevalence of CF microorganisms from 1991 until the most recent data in 2017. First, I'll call your attention to the blue line, which represents Pseudomonas aeruginosa, which has been declining in prevalence during this time period. I want to contrast that with the green line, which represents methicillin-susceptible Staph aureus, or MSSA, which has actually been increasing throughout this period. And then finally, call your attention to the red line, which is methicillin-resistant Staph aureus, which had been increasing until about 5 years ago when the prevalence has overall been stable. Whenever I look at this figure, I have a little bit of trouble looking at the bottom part of the graph with the less frequent organisms because it's so crowded. So I asked Eliza Fink and her registry team if they could please blow that up for us and give us a better look at that bottom part of the graph. And what we see here in the orange line is non-tuberculous mycobacteria, which have been increasing over the last several years. We only started collecting data in the registry in 2010. And then I want to call your attention to the bottom line, which is actually Burkholderia cepacia complex, which is far less common, but which has been declining in prevalence over this time period. But different microorganisms are problematic in different age groups. So again, data from 2017, we're looking at different age groups ranging from infants under 2 years of age all the way up through adults. And what you can see in this graph, again, the blue line is Pseudomonas, is that it's relatively uncommon in children, and then it increases in prevalence until it becomes the most common organism in our adults. In contrast, methicillin-susceptible Staph aureus is the most common organism in children and then becomes progressively less common. And the biggest burden of MRSA is actually in adolescents and young adults. So again, I asked Eliza's team if they could please give us a similar graph for the non-tuberculous mycobacteria, and you note that M. abscessus and M. avium are equally common throughout young adulthood, and then M. avium becomes the most common non-tuberculous mycobacteria recovered. So clearly we have, as Bill mentioned, a remaining burden of infection in our population. So what questions are emerging for treating infections in the era of CFTR modulators? What will happen to microbiology among individuals who have established lung disease and are already infected? What about those who have less severe lung disease, but still we're able to culture organisms from their lungs? And what about those individuals without documented infections? Some individuals may not tolerate or respond to existing modulators. Some may not have effective modulators available yet, but everyone is going to need monitoring of their microbiology to guide therapy, and we still clearly need anti-infectives. So what have we learned so far about the impact of CFTR modulators on CF microbiology? So this is a study that looks at restoration of CFTR function associated with decreased Pseudomonas aeruginosa, conducted by Steve Rao and colleagues. They enrolled participants who were 6 years of age and older, who had the G551D mutation, and what you can see prior to, I gotta get this to work, prior to the start of ivacaftor, a little over 50% of the patients enrolled had positive cultures for Pseudomonas aeruginosa. That decreased after ivacaftor was started into the 34% range in the 6 months and the 1 year after ivacaftor began. This group then looked at the restoration of CFTR function associated with other microbiology changes. In this figure, the open figures represent prior to ivacaftor, and the closed represent after ivacaftor was started. We noted again that Pseudomonas aeruginosa decreased, as did mucoid Pseudomonas aeruginosa, as did Aspergillus, and overall there was a decreased frequency of isolation of Pseudomonas aeruginosa. The team in Dublin took a slightly different approach. They looked again at adult participants who had G551D and were placed on ivacaftor. 8 of the 12 of these individuals had chronic Pseudomonas aeruginosa, and note here in this part of the figure that in the few days after ivacaftor began, the density of Pseudomonas aeruginosa markedly declined. When these individuals were followed out to 2 years, the density rebounded. So clearly we have some really intriguing observations made around G551D and ivacaftor, but we need to make more observations as with the new modulators and more of the population receiving them. So I'm now going to play a video. This is an adult with CF named Trey LaRosa, who's going to share with you his experience dealing with chronic infections.
Hi, my name is Trey. I'm an adult living with cystic fibrosis. I'm 24 years old. My sister Alyssa also had cystic fibrosis. She passed away in March of 2018. She was 29 years old. Chronic infection is one of the biggest aspects of living with cystic fibrosis. It's, in my opinion, in my experience, fundamentally the biggest thing we deal with on a long-term basis, because your body's always actively fighting CF with the bacteria in your lungs. That means that we have daily maintenance medications and treatments to do, and we have to always be concerned of our environment and to be careful that we're risking further infection by colds and viruses. My sister Alyssa had 2 double lung transplants in the last 5 years of her life. So before that, chronic infection was really, really debilitating in her life. They tried all the antibiotics they could find or that they had at their disposal, and nothing worked. She didn't respond, didn't feel any better, and then progressively got worse. It was this consistent lack of efficiency with the drugs that really, really devastated her psyche, and it really took a toll on her because she didn't have a lot of hope that she would recover whenever she would get sick. Fortunately for me, I do tend to bounce back from medications, but seeing what my sister went through and knowing that at any point it's possible that I might not respond to the antibiotics, that is something that does scare me a lot. It encouraged me to really take my care seriously and to do my best to sustain care in whatever way I could. I believe it's extremely important for researchers to continue finding and designing better anti-infectives. Whether you're on a modulator or not, we're all affected by infections in our lungs. It really gives me hope that I have opportunity to continue maintaining my health. I think Alyssa was extremely grateful for the research that people do, and she would have hoped that the anti-infectives continued to get better because she never wanted to see anybody go through that, including myself.
Thank you so much, Trey, for sharing that with us. Yeah. So, as Bill mentioned to you, there was actually surveys sent out to clinicians caring for individuals with CF, as well as individuals with CF and their families, and they were asked to prioritize their research topics. And no surprise to me, and I hope many of you, respiratory microorganism detection and treatment was the #1 research priority that was identified by both groups. And this has led to the Infection Research Initiative. And this initiative is really incredibly important because it's dealing with not only understanding CF microorganisms better, understanding their detection and identification, looking at chronic treatments that we're using, looking at therapies that we have and how to optimize them, but also looking at new therapies of tomorrow and how we're going to deal with infections in the era of CFTR modulators. So I'm going to be spending the rest of my talk going through each of these different focuses and giving you a sense of what is going on in them. So how about that? So believe it or not, a decade ago, Michael Constant, Jim Schmiel, and myself gave a plenary called Inflammation and Infection and an update on the CF pipeline. And at that time, we described the natural history of acquisition of Pseudomonas aeruginosa, beginning with young children who often had negative cultures or intermittently positive cultures, then progressing to chronic infections, where cultures were persistently positive, with a conversion from the non-mucoid phenotype of Pseudomonas aeruginosa to the mucoid phenotype, and then finally progressing to the advent of biofilms forming within the CF lung. And each of those different stages of Pseudomonas aeruginosa in the life course of individuals with CF gave us insight into therapeutic strategies. So we talked about eradication strategies for intermittent infections. We, of course, talked about management of pulmonary exacerbations, and then finally chronic suppressive therapy with aerosolized antibiotics. So this was an approach that was addressing a single microorganism with different therapeutic strategies. But we now truly understand that the CF lung is a very complex microbial ecology. There are unique growth conditions within the CF lung. Available nutrition can sometimes be scant, and the metabolism of organisms may be very different than when they're living in other environments. And these changes can affect the activity of antibiotics, making them less active, as well as the mode of growth. And that seems to be the story for biofilms, as well as something called Staph aureus small colony variants. So I want to talk to you now about those. So the figure here shows fluffy white colonies, which are Staph aureus, that our clinical microbiology laboratories would normally grow and report back to us. But at the end of those red arrows are these tiny little pinpoint colonies that are these small colony variants that are the result of many, many mutations that we believe is the staph adapting to these conditions within the CF lung. Luke Hoffman and his team have shown that children that harbor small colony variants have lower lung function as well as an increased frequency of pulmonary exacerbations. So clearly we need to understand more about small colony variants, which also occur in other CF microorganisms. We are now appreciating that microorganisms are actually interacting with one another within the CF lung. And again, I'm going to do a shout out to Luke. He is credited with coining the concept that the microbial community may actually be the pathogenic unit. And we're starting to appreciate that these interactions may impact the progression of CF, the response to therapy, and ultimately clinical outcomes. So I want to share with you a series of experiments conducted by Jennifer Bomberger and her group at Pittsburgh that I think really explain these concepts well. They talk about the interactions between the organisms and also host interactions that could impact CF lung progression. So Jen and her group grow Pseudomonas aeruginosa in a biofilm, and they have shown that Pseudomonas biofilm growth is enhanced by RSV co-infection. So in this model, they grow respiratory epithelial cells here. She then puts Pseudomonas on top of those, and they grow in a biofilm, and then she adds RSV to the mix. And what you can see in this picture, here's the control. The airway epithelial cells are in blue, the Pseudomonas is in green, and as soon as the RSV is introduced, you note that there's a lot more green consistent with this increase in biofilm development. So she has asked what is the proposed mechanism whereby this occurs, and has introduced this topic of dysregulation of the host nutritional immunity. So normally, we, hosts, avidly sequester iron, but organisms need iron also. So what RSV infection does is it induces the release of iron-bound transferrin by airway epithelial cells that is mediated by interferon. And that is depicted in the panels below when there's no interferon present. Interferon then releases the transferrin. Now iron is available to Pseudomonas, and that increases biofilm growth. If you're interested in hearing more about this topic, it'll be discussed in Workshop 26 and Abstract 326. So promise me that you'll remember iron, because we're going to turn back to that later in my talk. Another focus of the Infection Research Initiative is improving detection and diagnosis. So conventional microbiology, such as that example I showed you earlier with Staph aureus, usually identifies single organisms. But we're now in an era where we have new molecular rapid diagnosis methodologies available to us. These can identify microorganisms directly from specimens. That's already being done for viruses, for example. And they may even improve our eradication strategies by earlier identification of lower airway infections. They may lead to more rapid turnaround time when we're trying to manage exacerbations, and ultimately holds the promise of decreasing the treatment burden for people with CF. These new methodologies have revealed potentially a more complex microbial community than I, for one, ever could imagine. So I want to call your attention to these very colorful panels that were made by John LaPuma's group, and each of the different colors represents different microorganisms in a single patient over time. So for subject A, the blue represents Staph aureus, and for subject B, the green represents Burkholderia. But there are a lot of colors there that represent microorganisms that we cannot grow conventionally in a microbiology laboratory that require these more advanced techniques. But I want to say that just because we're recovering the organisms doesn't mean that they're actually causing a problem in an individual with CF. So we have to now be able to correlate what I'm calling the structure, meaning the microbiome in this example, with the activity of the different organisms. So in this example, it would mean utilizing other tools, such as studying the metabolome, the transcriptome, and the proteome, which are actually what are the organisms doing, what proteins are they making, and correlating that with clinical outcomes. When we have the connections that we need for that, we can then use translational science to interrogate these systems and alter the different parameters in efforts to improve outcomes for people with CF. Also, I think we have to anticipate that we're going to be entering an era where our patients are healthier and healthier, and we're going to need to improve the detection of microorganisms in non-sputum producers. The table on the left shows you the results of a study that was conducted at Sick Kids in Toronto by Felix's group, and they used induced sputum, and no surprise, I think, they were able to detect organisms that were not detected by throat swabs, including Staph aureus, Haemophilus influenza, and Pseudomonas aeruginosa. But many CF clinics have indicated that doing induced sputum is quite cumbersome, and so we need new diagnostic techniques. So I am very excited to share with you the right side of the panel. This is work done by Jane Hill's group, where she used a methodology called two-dimensional gas chromatography, time of flight, I know this is a mouthful, mass spectroscopy. And I know I did it. And what she was able to do that I think is also really a crucial part of our community is she was able to take advantage of biobank that had BAL specimens, and she then looked to see what volatile metabolites were expressed in each of the BALs, and then correlate that with the presence of different microorganisms. So what you see here is this is the pattern of volatile metabolites that Pseudomonas aeruginosa makes. Compare that pattern with what Staph aureus makes, and a pattern from BAL where no organisms were detected. So these fingerprints, so to speak, are biomarkers that can really help us identify CF microorganisms. So potentially a really exciting methodology. So for a moment, take a journey and imagine with me precision medicine for CF infections, where we're able to abandon conventional microbiology in favor of rapid molecular detection using point-of-care devices that we can deploy in CF clinic or at the bedside in the hospital that will allow us to integrate information about the polymicrobial community and use that information to guide therapy. And I don't think it's that far away. So a decade ago, where were we? Well, we were talking about early eradication clinical trials. We were talking about the ELITE study conducted in Europe and the EPIC study conducted in the United States, and we devoted a plenary to early eradication. So the next part of my talk, I want to talk to you about optimizing current treatments. We really want to continue to do that as a community. So one of the examples I'm going to give to you is aptly named the Optimize trial that George Reich-Bogart, Bonnie Ramsey, and Nicole Meyer-Hamblett led. And it had been noted that even when children were undergoing eradication therapy, that they still experienced exacerbations. So they wanted to reduce the frequency of exacerbations and added azithromycin to the aerosolized tobramycin regimen. And it's noted in the figure that the children that received azithromycin had fewer pulmonary exacerbations, a 44% reduction, as well as a 1.27 kilogram weight gain, but there was no impact on microbiology, which is not unexpected because azithromycin does not have activity against many CF pathogens. Another exciting example of optimizing our current therapy, I think, is exemplified by the STOP-2 trial, which is underway. In this study that is being led by Patrick Flume and Chris Goss, they're trying to compare different durations of therapy for pulmonary exacerbations. And so they're dividing the population into what are called early robust responders. Those individuals will be randomized to 10 versus 14 days, versus the non-early robust responders based on improvement in lung function and symptom scores. Those individuals will be randomized to 14 versus 21 days. Before I leave this slide, I want to call your attention to this table because the CF clinicians were asked what was their number one priority, what were their priorities for managing exacerbations, as were individuals with CF and their families. Note here that clinicians put duration of therapy as the number one goal, whereas patients and families put that as a number 4 goal. But I hope that you can appreciate that some of the other questions that were being asked, such as the prolonged infusion beta-lactam agents or the use of corticosteroids during exacerbations, could be addressed by studies such as this one. And as of October 1st, 701 of the 880 patients that are required for this study have been enrolled and recruited, and I know that we're all looking forward so much to hearing the results of this incredibly important study. Now I want to turn to improving the management of nontuberculous mycobacteria because, as I showed you earlier, this is a pathogen that is increasing in frequency in our population. There have been clinical observations made that fall into 3 different groups. The first is that in some individuals, NTM may be transient. In other words, it's only recovered once and then it's never recovered again. In other individuals, it may remain indolent, so despite persistently positive cultures, there's no real impact on the person's clinical course. And then the final group would be those individuals where nontuberculous mycobacteria is associated with a progression of CF lung disease. There was an international effort to write and disseminate diagnostic and treatment guidelines, shown here, and I had the good fortune of participating in this effort. So this has led to 2 important studies that I want to share with you. The first is prospective evaluation of NTM disease in cystic fibrosis, or the PREDICT study. This study is a prospective observational study being conducted in the pediatric and adult Colorado CF centers under the leadership of Jerry Nick and Stacy Martiniano. They are using the algorithm developed in the consensus guideline to diagnose NTM disease, to try to figure out which of those 3 groups people have when they recover NTM. And they're addressing how to obtain the nontuberculous mycobacteria cultures, the radiographic studies required, the disease course, how to address other microorganisms and comorbidities. And the preliminary conclusions that the team has is that 42% of the PREDICT subjects actually met the criteria for NTM disease after a median of 5 months. Participants that were diagnosed with NTM disease had significantly lower lung function, significant and more rapid decline in lung function, and more frequent constitutional symptoms, severe exacerbations, and acute decline in body mass index, or BMI. The team is also conducting a second study called Prospective Algorithm for Treatment of NTM in Cystic Fibrosis, or the PATIENCE trial. Again, this is an open-label treatment study that is using a single NTM treatment algorithm that was developed in the consensus guideline. The algorithm guides the selection of therapy, when to obtain NTM cultures, monitoring individuals, and managing the toxicity and intolerance that is an unfortunate consequence of the multi-drug therapies required. The inclusion criteria are age 7 or more, positive cultures for MAC, Mycobacterium avium complex, or M. abscessus, and a partnership between the CF care team and patients and their families, whereby the judgment of the CF clinician is that a patient will benefit and that the person with CF and or their family members agree with the proposed treatment. So preliminary conclusions from the patient study are that there is actually an improved culture conversion rate when compared to the historic rates that the team speculates may be due in part to optimizing CF care first, thanks to the PREDICT study. And now, PREDICT and patients are being expanded to other centers with obvious benefits. There'll be increased enrollment, which will increase our power to support the findings. We'll be able to test and refine the protocols. There'll be a greater geographic diversity and distribution. It will benefit more individuals with CF, and it will test the feasibility and build the infrastructure for future studies. So I want you to imagine with me again that the studies that I've just presented provide for us a framework for future investigations. They standardize an approach for diagnosing different disease-causing microorganisms. They can serve as a comparator arm if we want to investigate new treatment approaches, and they will support biomarker discovery. So another part of the Infection Research Initiative is evaluating long-term antimicrobial use. And I think it's really important that we revisit the long-term impact of drugs that we use chronically. There may be inadvertent drug interactions, intolerance, or toxicity, and most of these therapeutic interventions were really only targeting a single microorganism, but as we've been discussing, the CF lung may contain multiple organisms, so those therapies may be impacting them. And also, a deeper exploration of long-term therapies may allow us to improve care through improving personalized medicine. So I'm going to use the example of potential antagonism between long-term azithromycin and aerosolized tobramycin. And these are observations that have been made by Dave Nichols and his colleagues. So they did a secondary analysis of one of the aerosolized aztreonam trials, and they looked at improvements in lung function in individuals who had been randomized to tobramycin who were on azithromycin, versus those individuals who were randomized to azithromycin and were already on azithromycin. So I want you to look first here. So these were the people that were on azithromycin and randomized to Tobra. They did not have an improvement in lung function, and compare that with the individuals who are on aztreonam who had a marked improvement in lung function. This part of the figure shows us those people who were not on chronic azithromycin, and there's really no difference in the improvement in lung function. There's biologic plausibility to these observations. It turns out that azithromycin upregulates an efflux pump called MEX-XY that Pseudomonas aeruginosa has. And what MEX-XY does is it actually pumps out aminoglycoside antibiotics. So we're giving the antibiotic, but Pseudomonas is cleverly pumping it out so it's not able to exert its activity. But I hope we all understand that secondary analyses of clinical trials and in vitro observations need to be supported by clinical trials. So Dave is leading the study called Testing the Effect of Adding Chronic Azithromycin to Inhaled Tobramycin, or the TEACH trial, and as of October 1st, more than half of the individuals had been recruited, and we hope that by the end of 2019, it'll be fully recruited and we'll be able to share the results of this study. So the final objective of today's talk is to discuss current strategies that will result in the new anti-infective therapies of tomorrow. So I'm going to again ask Trey to tell us in his words his clinical trial experience.
I participated in a clinical trial for an anti-infective in January of 2017. Going into it, I was a little bit nervous because it required a 5-day hospital admission, but the research team I worked with was really great in explaining everything and making sure that I understood what I was a part of. They were genuinely concerned about my care. It made me feel good to be contributing to the advancement of CF medicine. It was just really cool to know that I was a part of something that is going to potentially make my life better, but also everybody else that's, affected by CF. I think it's great that there's been more of a focus placed on anti-infective research, because it shows to me that the CF Foundation is really committed to finding more options to combat the chronic infection that has such a large toll on the lives of people in the CF community. It gives the CF community something to hope for with their health. Hope's an important thing to us, and knowing that is something to look forward to.
Yeah. He is incredibly articulate. So, one more. Let's go back a decade. And here was the CF Foundation's anti-infective therapeutics pipeline in 2009. And the two agents that were available to patients were aerosolized tobramycin and azithromycin, and aerosolized aztreonam, tobramycin inhaled powder, arikayce, and assorted other agents were still under investigation. And today, we now have Caistin available, TIP available, end of September, arikayce available, and aerosolized levaquin is available in Europe. But note that all of these therapeutic interventions were directed at Pseudomonas aeruginosa. So I want to contrast that with today's therapeutic pipeline. And what you'll notice is that this has a lot of different colors. For example, you note that the red color is for fungal disease. The purple color is directed at multi-pathogens at once. The green for non-tuberculous mycobacteria. And the black one is actually to prevent ototoxicity from aminoglycosides. In addition, the Foundation is in discussion with 17 other companies for potential therapeutics, showing us what a robust pipeline that we have. So what are some of the approaches that we can use to develop new therapies? Well, we can borrow agents from other infectious diseases. There's an FDA-approved drug for multi-drug-resistant tuberculosis called bedaquiline. This agent has been shown in vitro in a zebrafish model and in small case series to have activity against non-tuberculous mycobacteria. We can alter existing agents to become inhaled agents, a common strategy for CF. And two examples of that are the use of aerosolizing itraconazole for allergic bronchopulmonary aspergillosis, or aerosolizing vancomycin for methicillin-resistant Staph aureus. But potentially even more exciting, we can repurpose drugs that are used for non-infectious conditions that have unique mechanisms of action. An example of that is gallium, that is being explored for Pseudomonas as well as other pathogens, and I'm going to talk to you about that in another moment. Calcium EDTA is also being explored for several pathogens. Calcium EDTA is available to us now for heavy metal poisonings as it sequesters ions, and that can be explored for many organisms. In addition, inhaled nitric oxide, which is a smooth muscle relaxant, is being explored for Pseudomonas and non-tuberculous mycobacteria, and there have been very interesting observations made in patients with NTM on nitric oxide, as well as an agent called granulocyte macrophage colony stimulating factor, or GM-CSF, which is being used for non-tuberculous mycobacteria. So what is the mechanism of action of gallium? Well, remember I told you to remember iron. Bacteria need iron. They need it for DNA synthesis, for their oxidative stress response, and other metabolic functions. It turns out that gallium and iron are the same size. They have the same ionic radius. So the idea behind gallium is to fool bacteria into using gallium instead of iron. So Chris Gox and colleagues conducted a proof of concept phase 1b study in which they took 20 adults with CF who had chronic Pseudomonas, and they gave them 5 days of IV gallium, and you'll see here that at 14 days and at 21 days there was sustained improvement in lung function. If you want to hear more about this, it's being discussed in Workshop 17 and Abstract 307. So what are the future questions for treating infections with increasing access to the CFTR modulators? Bill talked about this somewhat. If we use CFTR modulators prior to infection, will people remain infection-free? Will infections occur later? Or is it possible that we'll see emerging pathogens that we haven't even thought about yet? And will those become problematic? I think it's likely that our current treatment paradigms may change, and our research and clinical approaches to infections will need to evolve. But we're poised to do that, thanks to the PROMISE study, which is being led by Steve Rao and Dave Nichols. This is a prospective study to evaluate biologic and clinical effects of significantly corrected CFTR function, which is a mouthful at this time in the talk. And here are the study designs, objective, and population. This is going to be a 2-year prospective observational study of short and long-term clinical effectiveness of the next generation modulators. The objectives of this study are to explore the impact on lung function, sweat chloride, symptoms, and body mass index, and there will be focused sub-studies embedded in PROMISE that will assess microbiology, inflammation, and gastrointestinal issues. The microbiology component, which is being led by Luke Hoffman, Dave Nichols, and Pradeep Singh, will look at changes in microbiology, the lung microbiome, and the GI microbiome, as well as the metabolome. This study will be a very rich source of biobanks for future studies. The plan is to enroll 400 people with CF who are 12 years of age and older, who are either Delta F508 heterozygote or Delta F508 homozygote in stable health, who are willing to maintain their current therapies for at least 6 months. And I know that you can share with me how exciting it will be when the results of this are available to us. So a lot of research, a lot of needs, and we have an amazing toolbox available to us to conduct this research. We have highly motivated partners, people with CF, their families, and the care center networks internationally. We have the research tools. We have incredibly strong collaborations around the world, funding resources, industry partnerships to fill up that pipeline, an infrastructure to conduct safe clinical research, biobanks, and I hope all of you out there are now thinking about new ideas that you can contribute to this effort. So it takes a village to give this kind of a talk. I really want to acknowledge all of the people on the left side of this slide. I called them, I nagged them, we had lots and lots of conversations, I borrowed slides, and without their help I wouldn't have been able to do it. I also had the backing of an incredible team at the CF Foundation. And then I also want to really thank all of the study groups and all of the people with CF that participated in these studies that I have presented here today. And I hope I've gotten you really interested in infections. This is just a list of the symposium and workshops, and there are lots and lots of posters that are waiting for you to go and look at. So thank you all for your attention, and please join us afterwards to the opening reception that'll be out in the concourse. Thank you so much.